Loop diuretics. Imagine a patient who is literally drowning in their own body fluids. Lungs filling with fluid, legs massively swollen, blood pressure dangerously high. Within minutes, one class of drugs can begin removing liters of excess fluid and dramatically relieve symptoms. These are the loop diuretics, the most powerful diuretics in clinical medicine. But why are they so much more potent than thiazides? And why do they also cause loss of calcium, hearing damage, and severe electrolyte disturbances? In this video, we'll answer all these questions. What are loop diuretics? Loop diuretics include furosemide, bumetanide, torsemide, and ethacrynic acid. The most widely used drug is furosemide. Bumetanide is highly potent and can be administered both orally and intravenously. Torsemide has a longer duration of action, allowing more sustained diuresis. Finally, ethacrynic acid is unique because it is non-sulfonamide, making it the preferred option in patients with sulfonamide allergy. Together, these drugs are known as high-ceiling diuretics because they can remove large amounts of sodium and water in patients with severe fluid overload. Site of action. Loop diuretics act on the thick ascending limb of the loop of Henle. They inhibit the sodium-potassium 2-chloride cotransporter, also known as the NKCC2 transporter, located on the luminal membrane of tubular epithelial cells. Mechanism of action. The mechanism of action of loop diuretics begins with NKCC2 inhibition. These drugs block the luminal sodium-potassium 2-chloride cotransporter in the thick ascending limb of the loop of Henle. As a result, reabsorption of sodium, chloride, and potassium is prevented, leading to marked urinary sodium, chloride, and potassium excretion, which produces powerful diuresis. Blocking this transporter also reduces the medullary osmotic gradient, decreasing the kidney's concentrating ability and promoting further water loss. In addition, inhibition of NKCC2 abolishes the lumen positive potential, causing loss of calcium and magnesium reabsorption and increasing urinary excretion of these divalent cations. Finally, loop diuretics increase prostaglandin synthesis, producing renal vasodilation and improving renal blood flow, which further enhances their diuretic effect. Therapeutic uses in hypertension. Although loop diuretics are not first-line drugs for uncomplicated hypertension, they play an important role in specific situations. They are preferred in renal insufficiency, especially when the GFR falls below 30 milliliters per minute, because thiazides become ineffective, whereas loop diuretics remain effective. They are also the diuretic of choice in hypertension with edema, such as in congestive heart failure, chronic kidney disease, and nephrotic syndrome, where rapid removal of excess fluid helps lower blood pressure. In hypertensive emergencies, loop diuretics are often combined with vasodilators to control volume overload. Finally, in resistant hypertension, they are added when fluid retention persists despite other antihypertensives. The key point to remember is that loop diuretics are particularly valuable whenever hypertension is accompanied by impaired renal function or significant fluid overload. Other therapeutic uses. Besides hypertension, loop diuretics have several important therapeutic uses. One of the most critical is acute pulmonary edema, where intravenous furosemide rapidly relieves pulmonary congestion by removing excess fluid from the lungs. They are also widely used in congestive heart failure to reduce edema and fluid overload, thereby improving symptoms such as breathlessness and peripheral swelling. Another major indication is edematous states, including nephrotic syndrome, chronic kidney disease, and liver cirrhosis, where they help mobilize excess body fluid. Loop diuretics are also useful in hypercalcemia. When combined with saline infusion, they increase urinary calcium excretion and help lower serum calcium levels. Similarly, in hyperkalemia, they promote potassium excretion and assist in reducing serum potassium. Finally, in selected patients with acute renal failure, loop diuretics may be used to maintain urine flow, although they do not improve overall renal recovery. Electrolyte disturbances. Electrolyte disturbances are among the most important adverse effects of loop diuretics because these drugs produce a powerful loss of electrolytes in the urine. The most common abnormality is hypokalemia, which can increase the risk of cardiac arrhythmias, especially in patients taking digoxin. Loop diuretics may also cause hyponatremia, which can be either dilutional or depletional depending on the patient's fluid status. Another important effect is hypomagnesemia. This occurs because inhibition of the sodium-potassium 2-chloride cotransporter disrupts the lumen-positive gradient, reducing magnesium reabsorption. Finally, unlike thiazides, loop diuretics increase urinary calcium loss, leading to hypocalcemia. This difference is clinically important and helps distinguish the two classes. Therefore, regular monitoring of serum electrolytes is essential during loop diuretic therapy. Ototoxicity. Ototoxicity is a characteristic but relatively uncommon adverse effect of loop diuretics. These drugs, especially ethacrynic acid, can cause dose-related hearing impairment, which may present as tinnitus or hearing loss. The risk is highest with rapid intravenous administration, so loop diuretics should be given by slow IV injection whenever possible. Patients with pre-existing renal impairment are also more susceptible because higher drug concentrations can accumulate in the body. Ethacrynic acid carries the highest ototoxic risk among all loop diuretics. Other adverse effects. In addition to electrolyte disturbances and ototoxicity, loop diuretics have two other clinically important adverse effects. First is hyperuricemia. Loop diuretics compete with uric acid for tubular secretion, reducing uric acid excretion and increasing its concentration in the blood. As a result, they may precipitate gout in susceptible patients, particularly those with a previous history of gout. Another important consideration is sulfonamide allergy. Furosemide, Bumetanide, and Torsemide are sulfonamide derivatives and may cause allergic reactions in susceptible individuals. In such patients, ethacrynic acid is the preferred alternative because it is not a sulfonamide. Key takeaways. As we conclude, let's summarize the key points about loop diuretics. First, they are the most potent diuretics, also known as high-ceiling diuretics, because they produce powerful diuresis by inhibiting the NKCC2 cotransporter in the thick ascending limb of the loop of Henle. Second, they have broad clinical use. They are indispensable in conditions such as pulmonary edema, congestive heart failure, chronic kidney disease, hypertensive emergencies, and hypercalcemia, where rapid removal of excess fluid or enhanced calcium excretion is required. Finally, always monitor patients closely. Regular assessment of electrolytes, uric acid, and hearing is essential, particularly during intravenous therapy or when using ethacrynic acid, which carries the greatest risk of ototoxicity.